have to keep injecting prior to the surgery. We just call each patient and have the surgery very quickly. This is for one patient. Okay, so if you're going to use for bony procedures, you will need a large amount of WALANT. So just for an easy guide, a patient who's about 60 kilograms, you can put up to 50 mils of WALANT. And remember to give analgesia to the patient because they forget that their hand is numb, because the numbness will last about 7 to 8 hours. So if it's simple surgery, you can just give NSAIDs and paracetamol. But if it's extensive surgery, you do some plating of the radius or plating of the metacarpal. Make sure you give tramadol as well. Again, it depends on the patient pain threshold. But usually just the first night is painful. After that, they are okay. Okay. I also want to say that WALANT is not really for all patients and not for all surgeons and not for all operative procedures. So for the surgeon, if you are not confident with the surgery, it's the first time you're doing that surgery, you please do it under GA. If the duration of surgery is going to be more than 2 hours, and if there's some new plates or instruments involved, if the fracture is comminuted or difficult, multiple fractures which are older than 2 weeks old, and of course deep bone fractures like humerus and shoulder, those are all to be done under general anesthesia or regional anesthesia. For the patients, if they're allergic to lignocaine, if they have peripheral vascular disease, if they are hyperanxious or needle phobic, psychiatric patients, uncooperative patients, language barrier, then do that and do those cases under GA. If the patient is obese as well, because the needle will not be able to penetrate all the way down to the bone. Right, so I'm just going to show a short video of metacarpal plating. Just under WALANT, where we give the injection subcutaneously. So this is the fourth metacarpal, the fracture. So first you give along the area of incision, of your projected incision, and it's just subcutaneous first. And you see that the needle is always in the swollen area. That means it's anesthetized. So after the orange needle, change to the blue needle as you go deeper in. So straight down to the bone, and then you inject 2 mils, and then you go radially another 2 mils, and then another 2 mils. Right. So at this point, we've used up to 10 mils WALANT. So you can go up to 30 mils. It's always good to have more than less. More WALANT is better than less. And you can see how swollen it is. So you need to wait about 1 or 2 hours before you do the surgery. And this also, you have the best. Genggam. Buka. Genggam. Buka. Okay, ni lurus ni. Okay, genggam. Buka, lurus. Okay. Let us set checking for rotation. Okay, right. So, oops. Yeah. All right. So that's all. Thank you very much. This is with me and my patient. Always good communication with the patient. And yeah, and that's my LinkedIn if anybody wants to get in touch with me.
Thank you. Thank you so much. It was really a wonderful talk. First of all, we will ask whether there are any questions on the chat box. And if there are no questions, then I would like to, Dr. Shalimar, may I know, have you ever experienced about like converting your WALANT into general anesthesia or regional anesthesia, or you have always been successful?
Yes, I have had one patient who was very, very anxious. So I mean, actually, like I say, one of the factors is I shouldn't have given him WALANT because he was anxious, but he wanted the surgery done quickly. He didn't want to wait for the elective general anesthesia list. So halfway through, he was like scared, and he was like, we gave a lot of WALANT, but he said he can still feel the pain. He can still feel the pain. So what we did is we gave him sedation. So
Mm-hmm.
we gave him some midazolam, and some Pacidin, and then he was okay. But I haven't had to convert to GA per se.
Okay, okay. And do you feel adding sensor cane in this lignocaine may have better pain relief for longer duration, or it has not been described that way?
You mean Marcaine?
Yes.
Okay, so the reason why Dr. Lalonde doesn't put Marcaine is because Marcaine has a higher amount of toxicity, a higher possibility of toxicity. So that's why it's always just lignocaine and adrenaline. Yes, Marcaine can extend the surgery, the numbness, but only for 2 hours, whereas WALANT is up to 5 hours or 6 hours. And Marcaine, you have the sensation does not come back. Pain comes back first, but their hand is still numb. So they have a numb but painful hand. Whereas
Oh,
for lignocaine, the sensation comes back first and then the pain comes back. So it comes back together. So that is why Dr. Lalonde does not use Marcaine.
yeah. And the common doubt, I am very sure those who are listening it, we have been explaining them many times, but I would like to, through this webinar, I would like to answer from you. Have you ever experienced any vascular compromise situation after giving lignocaine adrenaline in WALANT? Like ischemic changes in the hand?
Um, I had only one case where it was pale, but within 2 hours it pinked up again. Um,
Okay.
I used to have phentolamine, which is the reversal agent, but Malaysia doesn't actually have that. I actually took it. Dr. Lalonde gave it to me from Canada, and
Yeah.
I carried it with me for 2 years until it expired. Basically, I never had use for it. So now I don't use it. So only that one patient where it became pale. But I've done thousands now, maybe 3,000 cases. Um, no issues.
And do you give Valent to more than 65-year-old age group people also?
Yes,
There is no
yes,
problem.
no problem.
Okay, okay. And apart from that, any carpal injuries or distal radius fractures you fix under Valent, or you do only hand fractures or tendon injuries under Valent?
Okay, so for me, yeah, just metacarpal and hand fractures. I don't do distal and radius because
Oh.
I do have enough operative time
Hmm.
for distal and radius to be done under GA. But I do know in some of my other hospitals where they don't have the enough OT time, they will do distal and radius plating under WALANT.
Oh, okay. Dr. Nilesh, do we have any questions?
Yeah,
Yes,
this is
there
Dr.
is a
Selva.
question in
Excellent
the chat
presentation,
box.
Dr. Abdullah. Yeah. So I just one question from my side. I'm Dr. Selva speaking. Yeah. So
Yes.
in pediatric age group, from what age you consider Valent in pediatric age group?
Pediatric, when the patient is able to understand your instruction. So when we see the patient, when we talk to them, and if they say, oh, they are okay for it, I think 12 years old would be my youngest
Okay.
patient.
Okay.
There's a question here in the box.
Yeah, Dr. GK sir is asking that question. Do you add a regional block like wrist block along with Valent? No.
So the answer is no, because WALANT is the regional block.
Mm. Okay, Nilesh, over to you. Any questions?
No, nothing
No,
particular.
then Selva, please introduce next
Yeah.
speaker. Yeah.
So thank you,
Thank
Dr. Shalimar Abdullah. Thank you so much for your lucid presentation. So now I invite the next speaker, Professor Jong-Won. He's from Korea, and he's a professor at the Yonsei University College, and he's going to speak about hand transplantation, the evolution and progress in Korea. Welcome, sir.
Thank you for your introduction. The India, I will share my yeah. Yeah, thank you. Today, good afternoon. My name is Jong-Won, plastic surgeon from Yonsei, Korea. Today, I'd like to talk about establishing hand transplantation in my country, how it is different, sometimes difficult compared to other countries when introducing the new medicine. I already know the India is the very developed for the hand transplantation. Dr. Mohit Sharma, Dr. Nilesh, Satbhai, he participated today meeting, and Dr. Rama, Dr. Kumar. So your country already developed towards the hand transplantations, but in Korea, although it is very small, the environment and atmosphere is wholly different from other countries. So I hope to introduce the Korean conditions for the new medicine, especially hand transplantation. We usually remember the first one just because it is the first, but the first is important because it becomes the starting point for the next. After getting more experiences, we can finally establish the system. The first hand transplantation in Korea was performed 8 years ago by Dr. Woo Sang-yeon. After 1 year, a legal framework was finally established. After that, 3 cases were performed by our team. Many people ask us why was hand transplantation in Korea so late, even though your medical capacity was enough. Some people pointed to the social consensus or traditional cultural values, but my answer is no. I think many countries had no hesitation to try. They did the first, the second, and the step by step, they finally established a system. But in Korea, the system had to be ready first, including the insurance. Of course, building up the first has an advantage for patient safety, but it is not easy to try something new. This is the VCA legislation timeline from the first operation. Other countries collected data and then set up the system. Korea started late, and the setup period looks short, but it was not short because we started building the system long before the first case. VCA has been defined as an organ in US, Europe, and Korea. Of course, other countries also have performed hand-face transplantation under their general transplantation law following their protocol. But in Korea, we must be defined in the medical act. So it is not a very hard process to get the allowed to perform the hand transplantation. So, I read a book introduction in the New England Journal of Medicine, written by the Dr. Gorantula and Dr. Andrew Lee, who already performs the hand transplantation in US. I read that kind of book during my fellowship. I read it carefully and it made me think a lot. I looked for VCA meeting and participated one in 2008. This Congress meeting later became ASRT, American Society for Reconstructive Transplantation. When we began preparing for face and hand transplantation 16 years ago, we faced many challenges. First of all, plastic surgeons did not know the evolution of the transplantation, and transplantation surgeons did not understand the urgency and necessity of the reconstruction. They didn't understand each other well, and sometimes they just ignore each other. These 3 institutes are important in Korea to perform the medical performance. However, they shifted the judgment and responsibility to each other's. The government said, get approval first, whether from IRB or new technology, and then we will consider legislation. The new technology said we cannot assess it without a law. And the IRB in my hospital asked us, why are you planning to perform the illegal operation in our hospital? Korea has just one medical insurance system operated the government under the Medical Act. All Korean peoples, all Korean nationals are automatically covered by the National Health Insurance. That means all hospitals, all doctors must be regulated, registered with the national insurance. It also means that every disease must be covered under the national insurance. So the patients without hand or with a facial deformity must be covered the national insurance under the law. So we cannot perform hand transplantation, face transplantation, even though we have the funding, we have the skillful doctor, we have the donation, we already have the patients. We cannot do it because the national insurance did not define the hand transplantation in the as the standard treatment in Korea. So the coverage decision are made through another institute, New Technology Assessment in Korea. So hand transplantation passed a new technology assessment in 2010, but legislation came 8 years later. Face transplantation passed 3 years ago, but it took 12 hours from the first applications. The hand transplantation study group composed of plastic and orthopedic surgeons played a key role in making it legal process, especially Professor Eun-seo Chan, Professor Park Ji-young, and me together. We made efforts to slowly grow up academic session in both plastic and transplantation society to education and announcing and introducing the hand and face transplantation to the society. I presented my work at ASRT in 2012. I also wrote VC papers to reflect the Korean VC environment to announcing and education the society. We shared our preparations for face transplantation and open to the public. Since the Transplantation Society is an important partner in VC, I consistently presented at their meetings. I presented regularly as my works. Our team has performed 3 hand transplantations since the legislation was passed. Our team consisted with the plastic surgeon, orthopedic surgeon, as we performed the operation and check the rejection, and transplantation and coordinator also play an important role to management of the whole process of the transplantation. Our team, we also shared our know-how in hand transplantations from research to the surgical setup. We summarized our experience and published it last year. Interestingly, I used my hand as a reference hand to make an intuitive final decision, even though we have already checked and reviewed the donor and recipient hand data. So our team performs the second-hand transplantation, but the first-hand transplantation after legislation. And this is my favorite pictures, and this is the meaningful case because we have the many competition debate and as the what is that? Tell the plastic condition. Because in the initial draft of the legislation, hand procurement was placed at the very last step. That means after donation, after procurement, the heart, lung, liver, kidney, after they finally hand transplantation team participated after finished all of the donation. So I asked that, said to them, after that, the escape time is over, as the hand is not meaningful. So we need to participate in the initial state. So the lower legislation law is modified to participate together with the general surgery team. And this is the short video, and and prepare a draft. and the dissection as the plastic surgeon. So we worked together, plastic and orthopedic surgery together step by step. We have just two expert surgeons. We perform all of doing by together, step by step. Orthopedic surgeon performs the open and microsurgery and the perfusion and check the perfusion. And then doing together this surgery. And we frequently checked in the operation period, because I didn't want to return back to operation. So although we took so much time since we performed the complete operations at the steps. And the dressing, and finally finish the operation. So we made a protocol. This protocol we use the cardiac simulation protocol. It is we let's make the same protocol. Make the same protocol. I'm sorry. And this is. Yeah, this is a daily exercise as it is just overloading. Yeah, so I will passing. Most of the driving vehicle is consistent with the touch screen. So I think hand transplantation is only the methods to manage the touch screen, I think. So this is the first patient and the second patient. But he trauma in the high school ages, and he performs the hand transplantation 30 years later. So most of the muscle atrophy, muscle is atrophied. So the function, although it is the function is not so good compared to the other patients, but he's satisfied because he can holding the smartphone and holding the banquet or holding the umbrella. So he is very happy, satisfied the hand transplantation. And of course, complete build up the system has its merit. We could just focus on the patient without worrying about funding or regulation issues. Since around 60% of the cost was covered by national insurance, patients' financial burden was reduced. Yeah, the atmosphere around Westin Korean medical community has shifted from the blame to the favor and acceptance following the successful result of hand transplantation and legislation. I presented a Korean experience at ASRT 3 years ago. It was a great honor for me to have our institute listed. I had attended ASRT since my fellowship days, and so it was truly meaningful to me to be part of the program. Dr. Jiminoff encouraged me and shared someone was. She said, not rushing, not jumping, and emphasized orchestrating. I heard so many blame before when I prepared the hand transplantation. But the most important thing when you try something new is to have a steady and unshakable mind, like a heavy stone Buddha. I once read an article questioning digital cameras when I was a high school student, but these days no one uses the film anymore. So we don't know the futures, but we can be the part of building it. Yeah, thank you. And this is Paris, Korea will be held on the next November. Thank you so much for your attending. Thank you.
Yeah, thank you, Professor Hong. It's very interesting to know. So the most important thing I liked in the presentation is you mentioned that you took so much years for the preparation for the program. It doesn't happen. Usually, most of the country, they happen, but the time you are taken for the legislation and probably the background work you've done is so well. So it had so many years for you to successfully bring out the program. Excellent. Yes. So my first question for you is, so in India, if you see, most commonly we do a bilateral hand transplant. You have done all the three is a unilateral. How about in Korean? I mean, how do you choose?
Yes. Whenever I read and watch your India's cases, I envy your system, because most of the India hand transplantation, there are so many bilateral hand transplantation. So, regretfully, in Korea, 4 cases of the hand transplantation just performs the distal part. As you know, the distal part of hand transplantation is the easy hand transplantation compared to the upper and bilateral. So we have planned to build up the distal part, proximal part, and extended the bilateral and upper. And Dr. Sharma recently performed the shoulder level. So it is not easy in Korea because the donor sharing. The government considers the hand transplantation is not completely set up in the world. The Korean government medical part consider that. So they restricted the donation must the hand transplantation donation must be gathered at your hospital, not shares the patient. So although the kidney or the liver is the shares the donor patient other hospital, but the hand transplantation patient must be performed to your hospital donation. So it is beginning to build up, but after the corona, the system is just stops. So we just plan to extend the donation. So after that, we will build up the upper level and the bilateral level. And the other restriction is as you know, in Korea, plastic surgeons, hand surgeon in plastic surgery is decreased. So there are the hand transplantation doctors is not increased. They just interested, but they don't participate in the hand transplantation because, as you know, it is very hard and the rare cases. So I think if he performs the bilateral hand transplantation, I think the hand surgeons needed is for maybe 3 or 4 doctors, but in our institute, plastic surgeon, me, and the orthopedic surgeon, just 2 surgeons performs all of everything. So it is not easy to perform the other things. Yeah.
Great to know. So what is your, this is a question from Nilesh. So what is your average waiting time after registration of a patient in Korea? How good is the donation system? Because here the major bottleneck in India we feel is the donor, because they feel the body is mutilated and the donation is very less. So how about in Korea? And what is the average waiting period of a patient after registration?
I don't know exactly the major organs, but I think after Corona, before the Corona, the donation patient, brain death donation patient is increased. But after Corona, the number of the donation is decreased. And especially hand donation is more decreased. So we just performed the 3 cases. The first patient we performed after one and a half year later. after success the first hand transplantation in my institute, many patients who wanted a hand transplantation visited my clinics. So they just waiting waiting. Three patients. The three patients just waiting the 1.5 or 2 years, but there is no no donation. They waiting the 3, 4, 5 years. Yeah.
So any of your patients had rejections, or how you manage? I mean,
our institute, we performed three cases of hand transplantation. Fortunately, our patient, the first patient is 5 years, and the second is 4 years and 3 years. They hand is very good. They visited last month. It is very good. So, unfortunately, first cases already performed 8 years ago. The transplanted hand is rejected 2 years ago. Yeah. So survivor hand transplantation in Korea is 3 cases. Yeah.
So what is the tacrolimus level you maintain for these patients?
Oh, excuse me.
Tac level.
Yeah, tacrolimus. Yes, tacrolimus. Yeah.
What level you maintain the maintenance?
Maintain level is the maybe the first patient is after 5 years the maintain level is 5 or 6. But and the third patient also 7 or 8. But as the transplantation surgeon who prefers to use prescribe the tacrolimus, the first patient as the first year, so we usually maintain around 10. But maybe yes, but at the first cases we have no experience as the first patient level down the 5 or 6. At that time we experienced the first rejection, so we build up the tacrolimus level to the 10 and maintain the 1 year. After that we tapering to the level to the 5 or 6. Yeah.
In all the 3 transplant, have you done any revision surgery to improve the function?
Yes, tendon transfer. Of course. After 1 year, tenolysis and fusion fusion is performed 3 of the patients, and we experience skin necrosis. Because of that is not rejections. That is because of the previous trauma and scar tissue. I have not so much experience about the scar tissue transplantations. I am worried about I'm worried about if I use the transplanted hand. I think I thought there are so many chances to the rejection. So I remained the scar tissue, the recipient scar tissue. But the scar tissue is not. The blood supply is not so good, so we performed the skin necrosis. The several revisions was performed. Yeah.
So how is the patient compliance in your system? How does the patient, how happy are they after the transplant, and how is their compliance after the transplant? Patient compliance.
There's no one complain about that. But fortunately, there's no one complain about the hand transplantations. But when I performed the first hand transplantations, the family, his wife, is happy, but the patient first or 2 days after first or 2 days in the ICU care, the patient, although a lot, he cannot accept his hand because he is scared about the other. So when I watch, I expected he will be happy, but he was not happy at the time. So I worried about, I doing something well? My job is good or bad? I at that time I also confused what I do. Yeah.
Okay. Thank you so much. Any more questions? There's no more questions in the chat box. But thank you, Professor Hong. Thank you for your wonderful presentation.
Yeah.
Thank you so much.
Thank you so much.
Yeah, here I take the opportunity to invite our dear sir, Dr. GK sir, for his presentation on PIP joint fracture dislocation. Over to you, sir.
Yeah, thank you everyone for giving me this opportunity to talk among such great surgeons. Now, I'm going to talk about a little controversial topic because it's a little confusing about what is to be done. Proximal interphalangeal joint fracture dislocations. I'll talk about a little introduction, the classification, and then different types of classification, and we'll go into the theme. Now, it is basically phalangeal base fractures. That is the basic problem here in these injuries. So among the middle phalanx base, we need to understand a little anatomy before we go into. This is the volar side. You have the joint capsule, which goes all around. You have the extensor, that is the central slip attaching to the middle phalanx base. Then the flexor distal superficialis, attaching a little distal to the base of the middle phalanx. And then the ligaments, the collateral ligaments, the proper collateral ligament and the accessory collateral ligament. The proper collateral ligament going from bone to bone and accessory collateral ligament going from bone to the capsule or the volar plate. So if you classify it, you have partial base fractures, which could be dorsal like this, or you could have volar base fractures like this, or you could have lateral base fractures like this. Or you could have complete base fractures where the entire base is fractured, usually known as pylon fractures. Clinical classification is type 1 is where you have a volar lip fracture as it is called. Type 2 is a dorsal lip fracture. Type 3 is both volar and dorsal lip fractures. Type 4 is a basal fracture of the middle phalanx. It is not an intra-articular fracture. And finally, you have the medial and lateral. That is the lateral lip fractures, as I told you. So now let us see these partial fractures of the middle phalanx base. Now let us see this dorsal base fracture or the dorsal lip fracture. This usually results from a hyperflexion injury. And here, there is an avulsion of the central tendon, which may be present. So what we need to do is, if the avulsed fragment is displaced more than 2 millimeters, a boutonniere deformity will be present. So this has to be treated by accurate reduction and internal or percutaneous pin fixation. This can be done with short K-wires or screw fixation. The volar base fracture, on the other hand, this is also a partial type of base fracture of the middle phalanx. It results from a hyperextension injury or axial loading. Now here what happens, there is an avulsion of the volar plate along with this chip fracture on the volar side because the volar plate is attached. It is unstable. It is said to be unstable if more than 40% of the articular surface is involved. Then we come to the lateral base fractures. Here there is an avulsion of the collateral ligaments, as you can see in this X-ray. And the complete pylon fractures that I told you, both the lateral side base is fractured, it becomes unstable in all directions. This kind of fracture is a result of an axial load that causes a central articular depression and variable splay of the articular margins. Let us see what this means. So there are two configurations that can present in pylon fracture of the base of the middle phalanx. The first is a centrally impacted fracture along with comminuted fracture. This is called as a compression fracture. You can see this arrow mark that shows one segment of the base, usually the central portion of the base, is gone inside the middle phalanx, whereas the sides are comminuted. The second is with the T or Y type fracture geometry. This is known as an avulsion type of fracture because the two sides, that is the lateral bases, are avulsed from the base of the middle phalanx. So you have compression fractures where it is impacted, or avulsion fractures with a T or a Y pattern. Now, compression fractures the significance of these fractures is that compression fractures are not reducible by ligamentotaxis because they don't have any soft tissue attachments. Therefore, we will have to do a direct reduction. Whereas avulsion fractures respond to ligamentotaxis, so our traction methods of management will be very useful. So imaging, the usual X-rays, we need to have a PA, a lateral and oblique. Not one of these, but all of these to diagnose completely. So here you can see just one view. It's not very clear, but the lateral view will show the volar lip fracture, which has occurred, and the subluxation of the proximal interphalangeal joint. That is the position that you can see. Now, there are two important signs that you can make out on X-ray when you have one of the base fractures of the middle phalanx. That is the dorsal V sign. Now, this happens because there is the middle phalanx actually subluxates, and after that, it will not be able to flex. Normally, the base of the middle phalanx should glide over the head of the proximal phalanx when there is flexion. But here what happens, it hinges. So it cannot flex now. So this is called the dorsal V sign. The second sign is the dorsal cortex of the proximal and middle phalanx will be non-linear. Now look at this. This is the line showing the dorsal cortex of the proximal phalanx, and this shows the dorsal cortex of the middle phalanx. You will find that they are not linear and they cut at an angle, and sometimes they are parallel. A CT scan can be done to assess the articular involvement or the amount of articular involvement and also the degree of comminution. Now, the principles of management of such middle phalangeal base fractures, the first is we need to get perfect reduction of the displaced articular bone. We have seen in either the compressed fracture or the dorsal lip fracture or the volar lip fracture, the articular surface is gone. And it is very important to restore this articular surface. And maintaining of this reduction of this dislocation is even more important. So we need to reduce the dislocation and we need to maintain this reduction till the healing occurs. And of course, edema control is important to reduce stiffness and contracture later on. So we'll now see the management of partial base fractures and management of complete base fractures. And as you know, we've got two types, the avulsion type and the compression fracture. So there are four main methods of management. Whenever we get a proximal interphalangeal joint fracture dislocation, we think of four main methods. The first is immobilization and splinting. The second is open reduction internal fixation, either with K-wire, Platen screws, or lag screws. The third important method is traction. Traction method of management, which could be either static or dynamic. And lastly, it could be in delayed cases, it would be arthroplasty, which is basically two types, volar plate arthroplasty and hemihamate replacement arthroplasty or HHRA. Now, what is the role of splinting? I told you there is a dislocation and it is important to reduce this dislocation. How will splinting help in such cases? The indications are if there is an open injury or a precarious viability, you do not want to go in and put a screw or wires or give traction, which will make the viability of the finger even worse. Here you can just manage with splinting, or if there are limited resources, you do not have access to a hand surgeon or you're not able to get a good theater for operating, you can do a splinting method. The technique is immobilization in lumbrical position with PIP joint straight for 3 to 4 weeks. This is not ideal, but it can be done in the indications which I have mentioned. And then later, after the healing has occurred, you start mobilization, but alternate it with straight splint support for the finger. Now look at this. I told you the open injuries, and here there is a little bit of problem, the viability of the finger. It is viable, but there was a little problem. So we did not want to give any traction. You can see the fracture over there, and you can see the dislocation that is there. So what we did was we just did a skin suturing, there was no tendon injury, and we did a immobilization. This is the movement you can expect. That's all. It is not very good movement, but at that particular point of time, because of the problem, it was managed with splinting. Management with K-wires, open reduction internal fixation with K-wires is quite useful for open injuries, especially extra-articular fractures like the type 4 that I mentioned. It is not ideal for the intra-articular fractures. And it is not possible naturally to start early mobilization because it will lead to loosening of the K-wire. And it involves 3 weeks of immobilization. And the advantage, of course, is you can remove the wire. But still, this also is not an ideal method because it does not get accurate reduction of the dislocation. Remember our aims, good reduction of the dislocation and at the same time maintenance of the dislocation. Now look at this finger again. You can make out the almost intra-articular, mainly extra-articular, this fracture of the base of the middle phalanx. And this we have put back and this has been fixed with the K-wire. And this is the healing and the result. You get back full flexion, full extension, but there is a limitation of flexion. The open reduction internal fixation can be done with plate and screws also. But for this would be ideal because it serves the purpose of reducing the fracture fragments and reducing the dislocation. It involves disimpaction of the fragments using a K-wire or dentin. These are very small fractures, especially that central segment which has got impacted into the middle phalanx. Then we need to ensure congruity of the articular surface of the phalanx. And then we need to, this may result in a small void over there because after reducing the articular, getting the articular surface correctly aligned, you may find there is a gap for which you may have to put in a bone graft because otherwise it will keep collapsing. So the healing process may be delayed. So we need to put in a cancellous autograft to fill the impaction void. And the graft will also enhance the healing process. You can make out that impacted segment has been aligned now to the surface of the proximal phalanx, articular surface, and the bone graft has been kept. Now, as far as using plates and screws are concerned, there are 3 types of plates available. 1.5 mini condylar plate, 1.3 or 1.5 L plate, which is an adaptation plate, or a T plate. Any of these can be used according to the situation. The use of lag screws can also be done. I do not have any experience. This is a picture from a textbook where it shows the reduction and fixation of the volar lip fracture using lag screws. Or the dorsal lip fractures can also be fixed with lag screws. It all depends on the size of the avulsion fracture that has occurred. Now, I'll show you another technique which we used to follow, the method of traction. Traction can be of 2 main types. One we call as the skin traction or nail traction. Because all we want is, we want the fracture segments to reduce and to maintain the joint space. To have that, we need to distract the bone a little. So we use traction. We can use skin traction. And by skin traction, I mean, it is based on the principle of ligamentotaxis. It is indicated for closed injuries and when there are limited resources. Now look at this. This is the finger. These are the fingers. You keep them in lumbrical position. You apply a POP on the wrist up to the metacarpophalangeal joint crease. And then you apply a splint. Now, this is a long aluminum splint, and this is very cheaply available. You apply it in this direction, and then you apply another layer of POP over this. Now, this is going to be the supplying the traction, whereas the metacarpophalangeal joint flexion, that is going to be the counter traction. And the suture is applied on the nail plate, not on the nail bed. So this nail plate suture is taken with 3-0 or 2-0 polypropylene, and this is attached to the aluminum splint that we have applied. Now, this traction can be adjusted, and too much of traction will lead to problem of viability of the finger, and less of traction may lead to collapse of the joint. This must be adjusted. Now, look at this example. You can make out the basal fracture of the middle phalanx, almost a pylon fracture. and that is the movement in the finger, little finger. Now, this traction has been applied. You can make out the long aluminum splint, which has been covered with a white plaster. And this is on the, immediately we take a check X-ray. We also check the viability of the finger before sending the patient away. Now, this was the preoperative movement, and this is the post-operative movement after the therapy is given. Now, this is a non-invasive method of management of these fractures. Now we come to we have seen skin traction, now we come to skeletal traction. It is called dynamic external fixation. First, it was static traction external fixator described in 1946. Then it was dynamic distal traction splinting and early mobilization in 1986. And thirdly, it has now become compact and dynamic traction external fixator device that has been described by Suzuki. Now, how this dynamic external fixation, that is the Suzuki frame, is applied, I'm just giving a small diagram to explain. First, a 1.2 mm wire passed from the head of the proximal phalanx, and this is bent to go distal to the finger in this direction. Next, we pass 1 mm wire on the head of the middle phalanx that has been involved, and this is bent like this. Thirdly, we must make sure the distance between the wire in the middle phalanx and the distance between the wire in the proximal phalanx must be a minimum of 2.5 centimeters, because this is where the traction is going to be applied. That is the traction that's going to be applied in the form of a rubber bands. The third is the transverse K wire of 1 millimeter. Now, should this be applied dorsal to these previous wires or volar to the wires depends on the type of avulsion fracture. Supposing it is a dorsal avulsion fracture and this is the axis of the middle phalanx and the proximal phalanx, this wire, transverse wire, must be volar to this axis so that it helps in elevating or dorsalizing the fracture and reducing the dislocation. Similarly, if it is a volar fracture, lip fracture, and this is the axis, you put the transverse wire from the dorsal aspect. So this is an example to show this. This is a pretty bad fracture. This is the Suzuki frame that has been applied. In chronic cases, sometimes patients may present very late. There's a procedure called volar plate arthroplasty. I told you there are two procedures, volar plate arthroplasty and hemi-hamate replacement. In volar plate arthroplasty, when there is a loss of the volar base, even in acute conditions, when there is a loss of the volar base and no significant soft tissue attachment, or the vascularity is poor, or whatever little bone is there, it is not possible, like the techniques we have used, depend on those small bits of bone to come and heal over here and create the articular surface. But if there is a loss, or those little bone fragments are not healthy, there is no point in doing the methods that we have outlined so far. So they have to be excised. But naturally, a defect will be created, and for that, we can do one of the methods that I have told you. Now, volar plate arthroplasty is appropriate for unstable fracture reduction with more than 40% of articular surface involved, and unsuitable for ORIF or traction. It has been described by Eaton and Malarick in 1980. So here, this involves removing the comminuted portion of the bone. You can see the comminuted portion of the bone over there. That has been removed. Then what we do is, we advance the volar plate and it is attached to the bone with a button. Now this is the volar plate. Now this volar plate that has been reattached here, it is creating a volar plate arthroplasty, and this hopefully should get back some amount of flexion extension at the proximal interphalangeal joint. This joint is temporarily pinned in slight flexion, and this volar plate prevents the dorsal subluxation of the middle phalanx. But as I said, the results with this technique are unpredictable. There is a more predictable procedure known as the hemi-hamate replacement arthroplasty, which has been described by Hastings et al. In 1999, where the dorsal distal portion of the hamate replaces the volar base of the middle phalanx. We already saw an example where there is a defect in the volar aspect of the base of the middle phalanx. So, by use of this bone graft, we can get a rigid fixation and naturally early motion can be instituted. Now look at this example. That's the base of the middle phalanx, which has been lost. That is the volar side. I'm talking about the volar side. So here, when it is lost, you go to the hamate, which has got typically this shape between the fourth and the fifth metacarpal. It is articulating with the fourth and fifth metacarpal base. So we cut a bone like this, which is typically the shape of the middle phalanx base. And there we bring it over here, and then you put it in that area. Now look at the lateral view. The bone graft will come like this. It is almost perfect. Now the complications of the management of proximal interphalangeal joint dislocations, fracture dislocations, mainly stiffness and flexion contracture. The most common complication. In fact, I would even say that this is the rule that happens, and it is up to us to prevent this from occurring by correct treatment. Now, this flexion stiffness occurs because the accessory collateral ligaments are lax in flexion because of lack of extensor power. Central slip may be attenuated or flexor tendon attenuated. There are so many problems, but this is the norm rather than a complication. Chronic swelling may occur. Redislocation and subluxation may occur if too early mobilization is started before the healing of the fracture. And that is why proximal interphalangeal joint flexions are pretty complicated, but it is up to us to choose one of the 4 methods of management and utilize them exactly as they are indicated. Thank you.
Thank you so much, sir. That was really elaborative talk and very, very lucid presentation, sir. Sir, what is your threshold? Like you apply dynamic distraction, what is the time frame that you will consider? Beyond that, you will never apply Suzuki frame.
Yeah. Now, generally, I don't go beyond 2 weeks. Beyond 2 weeks, some amount of fibrosis is set in. I feel it will not be. However, I will take the patient to the theater. I will tell him that I will try to get a traction, but if I do not get it, I may have to change my method of management.
Oh.
Whereas if it is more than 1 month, definitely I will not try this traction.
And how long will you keep the frame, sir?
This is for 3 weeks. After 3 weeks, since this is dynamic traction, I will continue to ask the patient to start moving it. I find that once you remove the wires, patient will not come back to you. So I tell the patients that when you show me almost 90 degrees of flexion at the proximal interphalangeal joint, then I will remove the wires. So that will be an incentive for him to keep coming back to me. And I will also make sure that I am able to follow up the patient till I get back good basic movement at the PIP joint.
Oh, yeah. So, Dr. Nilesh, any question in the chat box?
No question, I think.
Yeah, Selva, do you have any questions?
So what you have told all about acute injuries, but majority of PIP which actually come across is actually a patient has been treated and come late. So what's the management case in which?
Yes. As I was saying, you get a lot of patients will come back with some treatment, and
Yes,
the complication of stiffness and contracture, they will present only with that. When they present with that complication, what my protocol would be, first I look for the clinical, how much of movement is still there in that joint. So am I going to preserve? The first question I need to answer is, am I going to preserve that joint? Usually, if it's a young person or something, or there is some amount of movement, I will say, okay, I'm going to preserve this joint. The second thing is, if it is not there, there's absolutely no movement, or the patient is presented late, I will plan for an arthrodesis. Of course, after discussing with him about his work and what sort of needs he has for the hand. The second thing is, once I notice a little bit of movement in that joint, I'll take an X-ray to assess the joint space. If there is enough joint space, then I will go ahead with a capsulotomy or a volar plate arthroplasty. If that movement is not there, I'm able to make out a joint space, I would go ahead with a hemihamate replacement arthroplasty. But beyond this, I feel that you may not get back full movements, or that the patient will have to understand. The most important thing in the treatment of PIP fracture dislocation is, at the very beginning, we need to tell the patient that he may not get back full function, or he may need other procedures like capsulotomy of the PIP joint or volar plate contracture release to get back good function. If the patient presents late, the choices are very limited. Like, for instance, I said, you look for the joint space, you look for the joint space clinically on the movements available, and you look for the joint space on X-ray.
Thank you so much, sir. Dr. Hong, do you have any experience of doing a free joint, microvascular free joint transfer in chronic PIP joint fracture dislocation?
No, I have not so much experience about that kind of patient. Yeah.
Dr. Shalimar, Dr. GK, sir, have you done any free joint transfer for PIP joint, or you never required to do that?
I haven't done that either. I've I had one patient with very, very bad fracture dislocation, and the patient came late. So I did one PIP joint replacement. But the replacement didn't do so well because the patient was very active. So I think I should have just fused the joint.
Yeah, I haven't done a joint transfer. I'm sorry, bone vascular is bone transfer. But there is one more option that I have. When the base of the middle phalanx is very bad, then I would think of removing the head of the proximal phalanx and making it as a sort of an excision arthroplasty. There is a gap over there, or a gap arthroplasty. This I can do depending on the patient's compliance and the requirements of the patient.
Okay.
A permanent answer would be an arthrodisc. That's a permanent answer. But these are all stopgap procedures to get back some amount of movement.
Sir, GK sir, what's the, when will you do a traction? Suppose if there's a fibrotic joint, then using a traction device. So,
yeah.
What is your, indication, or how long?
Yeah, acute injuries presenting with the pylon fracture, or even a dorsal lip fracture or a volar lip fracture. First, when I see them, sometimes, the patients present very early before the edema sets in. If those patients come to me, immediately I'll apply a traction. If the patient comes a little late, after 5 or 6 hours, what happens? There is some amount of edema that comes in. I feel that the traction cannot go against this edema. So I give a POP and wait for the edema to come down, maybe 24 to 48 hours. Then I apply the traction device. So that is my protocol.
Applying a mini fixator and doing a traction for a fixed joints, but joint stiffness.
Correct.
Creating the joint space.
You're talking about joint stiffness.
Yeah.
Yes. That's a good question, but I do not have any experience with the use of mini fixators for sort of opening out the joint. That's what you're talking about, isn't it?
Yeah, exactly.
Yeah, I haven't used it.
So you use WALANT anesthesia?
No, I haven't used so far.
So I think from now you should start using it, I think.
Yeah, I think listening to Dr. Shalimar's talk, he seems to give a lot of confidence. Now,
yes.
The question may be why I haven't used WALANT anesthesia.
Yeah.
The first thing is, she herself told in her talk that we are a little worried about the vascularity of the finger. Okay, but you have clearly said that it was the procaine that was used earlier that was the culprit, and not the adrenaline. Okay, now I have seen 2 presentations already about WALANT, and people have asked me, why are you not using WALANT? So here, I think this is one of the talks that have sort of inspired me to maybe I'll use WALANT and I'll let you.
Great.
Yeah, you can, but but anyway, you're going to put the POP first and wait for the swelling to go down. So maybe, you can do it under your elective, but still, it's nice to do it when you're fresh at 10 o'clock in the morning without having to wait for other big surgeries to happen.
The only other thing is, you said you have to give it and wait for at least 1 hour, no, to have a good effect.
Yeah, but bloodless. So if you're just doing your Suzuki traction, then you don't have to wait so long.
Yeah,
You can,
correct.
yeah, so 20 minutes you are okay to go, because unless you're doing the open reduction and putting a lag screw or something like that.
Yeah, correct. Correct. Thank you.
Okay, thank you so much. Over to you, Dr. Nilesh.
Okay. Fine. So I thank all the speakers and the moderators for a wonderful talks and wonderful discussion. And we look forward to carry on this camaraderie in Mumbai at the APFSSH. So I once again invite all of you for the meeting, and I request you to spread the word within your community and the country about the meeting, so that we attend in large numbers. And yeah, Parag, you want to say something?
Yeah,
Yeah,
so there
there's
is a
one.
question on from Vidocto, that what is the opinion of the panel on a tupper orthoplasty? Dr. GK sir, any idea? You
You're
are muted, sir.
We're muted, sir.
Yeah, I haven't used a tupper arthroplasty, but I do not know if anybody here has used it.
No, I have done it for proximal phalanx head degenerative changes, and for me 30 to 70 degree of range of movement we have got after that surgery. So it was only in one case. Mainly, probably it is considered either a complete destructed middle phalanx base, or when we have a erosion on the proximal phalanx head. That time we do that, but only one case. Beyond that, no. Yeah. Okay.
Thank you. Thank you all. Thank you, speakers. Thank
Thank you, Dr. Hong, Dr.
Nilesh,
Shalimar, Dr.
for
GK.
inviting us. Thank you. Thank you, Parag. Yeah.
Thank you,
sir.
Yeah.
everyone.
Thank you
Thank you all
all.
the
See you in
speakers.
Mumbai.
Thank you so much.
Thanks so much.
Thank
Yeah. Have a good week. Have a good weekend. Bye-bye.
you. Bye-bye.
Bye. Bye-bye, everyone.
Nilesh sir, shall I conclude the session?
Sure.
Thank you, sir. On behalf of Team Vidocto, I would like to extend our heartfelt gratitude to all the speakers for their insightful speech and the moderators for their extraordinary moderation. A special thanks to Dr. Nilesh sir for coordinating this session. I also thank all the delegates for joining with us today. Sir, with your permission, may I end the session?
Sure. Thank you, Shweta.
Thank you.
Thank you.
Recording stopped.